I just need a quick thumbs up if my audio and video is, if I'm visible and if you can hear me properly. Okay, great. So let us start with the dermatology predictor series for INICET. So we have 10 questions with us, and without wasting time, I'm starting with the first question. Just need a quick thumbs up, everyone, if you're ready for the first question. Great. Chal, we should start. Coming to this question, the first question, I hope it is visible. So this is a clinical picture attached to the question, and the question is, which of the following medicines taken during pregnancy is responsible for the defect seen in the child below? So you can see a child with a cleft palate and a lisp. Now they're asking you which of the following medication can cause this kind of condition among the options provided. So what I can say that among the options provided, it is your isotretinoin, which is an anti-acne medicine given for grade 4 acne, which is a nodulocystic acne. Isotretinoin, it is a retinoic acid. It's an oral retinoid, which is completely contraindicated in pregnancy. And in fact, we have to wait at least for 3 months after stopping the drug. 1 to 3 months strict contraception is required after stopping the drug because it stays in your blood even after stopping it. So this is the side effect which you get. You can also get some defect in the organogenesis. Please remember the side effects of isotretinoin, very frequently asked question in all the exams. So I will discuss briefly about all the side effects of isotretinoin. Now, first of all, what is isotretinoin? What is the chemical structure? Isotretinoin is 13-cis retinoic acid. This is the chemical structure of isotretinoin. Now, what are the side effects of isotretinoin? One of the commonest side effects. Can anybody tell me? Can anybody tell me what is the commonest side effect? If anybody have taken isotretinoin, just a 1 or 2 capsule of isotretinoin induces a side effect which is dryness. It starts over lip and it goes on the skin. So dryness is one of the common side effects. It alters the liver function test. It increases the triglyceride levels. It causes photosensitivity, and that is why if you have noticed, dermatologists give this drug at night. It causes pseudotumor cerebri. It causes DISH, which is diffuse idiopathic skeleton hyperostosis. And as we have discussed, teratogenicity. One of the dreaded side effects, and that is why we ask the patient not to take this drug. At least there should be 1 to 3 month strict protection or strict contraception after stopping. Now, always students ask me that, ma'am, if 1 month is also given and 3 months is also given in the option, what do we have to choose? So please remember, the 1 month period is a very risky period after stopping the drug. And that is why at least for 1 month, there should be strict protection or strict contraception. But if they're asking you a range, then up till 3 months, the risk remains in the body. So if you have to pick between 1 and 3, then pick 1 month as your best possible answer. But yes, if there is no 1 month given and if they're asking you about the range, 1 to 3 months becomes the best possible answer after stopping the drug. You have to take a strict protection of 1 to 3 months. Okay, understood this? Where do you have a 3-year contraception? So Stupidify is asking that, ma'am, is it 3 years or 3 months? Please remember, for acetretin, which is used for the psoriasis patient, so we have different type of oral retinoid. One is isotretinoin, which requires 1 to 3 months strict contraception. But there is another drug known as acetretin, which is not used for acne. It is used for psoriasis patient. There, the period of contraception is 3 years because acitretin is a lipid-soluble drug, but isotretinoin is a water-soluble drug which needs 1 to 3 months of strict contraception after stopping the drug. Okay, so I hope this question is clear. Just need a quick thumbs up. We are done with the first question, that is, which of the following drug causes this side effect? The answer becomes option number 1, that is isotretinoin. Moving to the next question, which of the following cells not present in stratum basal layer? So can you tell me what all are the cells which are present in stratum basal and what are the cells which are not present in stratum basal? What will be the answer of this question? Okay, so please remember the correct answer is Langerhans cell. Now let us discuss a little bit about the structure of your epidermis. Now please remember, in our epidermis, the majority of the cell is keratinocyte. That is, up to 90% cells are keratinocyte. The major chunk of cell is keratinocyte. And you all know that keratinocytes have arranged themselves into 5 different layers. Can you name these layers in which the keratinocytes are arranged in epidermis? Anyone? Yes, stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basal. These are the 5 layers in the epidermis which is made up of keratinocytes. Now, other than keratinocytes, there are 3 more cells. One is melanocyte. These are considered as pigment producing cell. It produces pigment, melanin. This gives color to our skin. Second is Merkel cell. They are touch receptor. And what type? Slow adapting type of touch receptors. And the third cell is Langerhans cell, which is an antigen presenting cell, the defense cell of our skin. Immune surveillance cell, Langerhans cell. Please remember, melanocyte is located in stratum basal layer. Merkel cell is located in stratum basal layer. But Langerhans cell is located in stratum spinosum. So other than Langerhans cell, keratinocytes, melanocytes, and Merkel cell, they're all seen in stratum basal. But Langerhans cell, which is a dendritic cell, it is seen inside your stratum spinosum layer. Understood this point? Clear hai? Can I get a quick thumbs up? Okay? Clear? Chalo. Great, great. Now coming to the next part. Next question. Third question. Tell me the answer. We have a 25-year-old girl presented with erythematous papule on the face as shown in the figure. Can you see? There is a very classical redness. You can see some papules and pustule on the face. The lesions were exacerbated on excessive sweating, sun exposure, and emotional disturbances. What will be the diagnosis in this particular condition? So anybody can tell me the correct answer. Now obviously this cannot be acne vulgaris. Why it cannot be acne vulgaris? No trigger. It cannot be photodermatitis because photodermatitis do not get triggered because of sweating, because of emotional disturbances. This again cannot be SLE because in SLE, the rash is static rash, means it do not comes and goes like that of the patients of rosacea. Now, this is a very, very important condition known as rosacea. Just a few quick description I want to give about rosacea. What is rosacea? As the name suggests, rosacea means like a rose. When the patient's face turned red like a rose. Now, who are these individuals? These are middle-aged individuals which look very normal. In general, on a daily basis, they look very normal. Their skin appears very normal. But whenever they are exposed to some triggers which could be sunlight, which could be exertion or exercise, which could be emotional disturbances like angerness, which could be consumption of alcohol, smoking, and taking spicy food. As soon as these individuals are exposed to these triggers, what happens? Suddenly they start developing flushing, that is redness and burning sensation on the cheeks. On the exposed part, or I should say convexity of the face. What is convex? The most convex part, this part, cheek, convexity of the face. These are the patients of rosacea. So they are middle-aged individuals who present to us with some redness and burning following these triggers. Now please remember, when these triggers are gone, the patient's skin turns normal. The patient's skin turns absolutely normal. But in SLE, the patient's skin remains, that malar rash remains throughout the course of illness. Whether there is any exposure to these triggers or not, the rash is always there. And that is why we call the SLE rash as a static rash. But rosacea rash is considered to be a dynamic rash. It just comes and goes. It do not stay there. Okay. So please remember, that is very important. Whenever you see a question with triggers and these triggers are making the skin red, when the triggers are gone, the skin becomes normal. Very classical of rosacea. Now, what can be the triggers? What is the cause of rosacea? So please remember, because of genetic predisposition, because of multiple use of cosmetics, patient develops Demodex, an organism known as Demodex on the face, and this Demodex makes your blood vessel wall abnormal, proliferate the sebaceous gland, giving rise to all the symptoms whatever we have discussed. So please remember, this is a very classical question with the description. This is your rosacea. For treatment, we have to give the antibiotics like metronidazole, doxycycline, and you have to ask the patient to avoid all these triggers. Okay. Now, coming to the next question. Can you tell me what will be the answer? The test which is likely to help in the diagnosis of itchy annular plaque on the face. First of all, think of a diagnosis. What can be the diagnosis here? You can see a very classical annular lesion. Annular means it has different consistency on the periphery, and you can see the center looks clear. Center looks clear. Periphery shows redness. So this is an annular lesion. Annular lesion with central clearing, very classical of tinea, fungal infection of the face. And what do you call the fungal infections? The dermatophytic infection of the face. You call it tinea facial. What test you will do? You will do potassium hydroxide mount. KOH mount will give rise to the KOH mount will give us an idea about the dermatophytic hyphae. You can easily demonstrate the dermatophytic hyphae, and this will help us in making the diagnosis. Please remember, whenever you see an annular lesion, an annular plaque, and the center shows clearing, this is a feature of tinea, fungal infection, dermatophyte, tinea. If the center shows crusting, leishmaniasis, cutaneous leishmaniasis, and if the center shows scarring, this is lupus vulgaris, cutaneous TB. So please remember, annular lesion with center difference, you have to always look for, and you get a lot of questions out of it. Okay. So please remember, for fungal infection, what do you do? Potassium hydroxide mount. Can you tell me what is the investigation of choice for cutaneous leishmaniasis? Anyone? What do you do? How do you demonstrate? Or you know that leishmaniasis is a protozoal infection. How will you make a diagnosis of cutaneous leishmaniasis? Anybody can tell me the answer here? Very nice. Please remember, you do Giemsa stain and you demonstrate Leishmania donovan body, LD body. So for fungal infection, KOH mount. For cutaneous leishmaniasis, Giemsa stain, and we demonstrate Leishmania donovan body. For lupus vulgaris, cutaneous tuberculosis, we do biopsy of the skin, and we demonstrate epithelioid granuloma, T lymphocyte. Okay, so this is very important microscopic or the investigations which we do, and it helps us in making the diagnosis. Okay. So very nice, Akansha, you're right. We do a Ginza stain, and for lupus vulgaris, we do cutaneous biopsy, skin biopsy. We demonstrate epithelioid granulomas. Amazing. Moving to the next question. Please tell me what is the answer of this question. A 50-year-old male presented to dermatology OPD. There is a violet color patch on the wrist. They're talking about this area. And if you remember, I told you the wrist, the palmar aspect, is a very common site for which condition? For lichen planus. Doctor noticed following characteristic lesions in the patient. Now let me just zoom this picture and let's see what is given here. Some white lacy lesions in the oral cavity. Okay. Some white lacy lines on the lesion. And can you see this? A very characteristic dorsal pterygium. The first picture is oral reticulate LP. The second picture here, this is the Wickham striae, and the third picture here, this is your dorsal pterygium, characteristic feature. Now they are asking you which of the following statement is wrong about this condition. Lesions show Koebner's phenomena, true. Please remember there are three conditions which shows true Koebner's. One is lichen planus, second is vitiligo, and third is psoriasis. All these three conditions show true Koebner's. Can you tell me the answer? Condition showing the pseudo-Koebner's phenomena. Anybody here can tell me the answer. Which are the conditions which shows pseudo-Koebner's phenomena? Just two names I want. Yes, molluscum contagiosum and viral what? So lesions showing Koebner's, LP, lichen planus, vitiligo, psoriasis. So that's a correct statement. Oral lesion look like a Wickham striae pattern. That is also correct. Wing-shaped projections of the proximal nail fold onto the nail blade, splitting and destroying the nail called as pterygium. That is also correct. But please remember, Nikolsky sign is a feature of the intraepidermal split. It's a feature of intraepidermal split. It is not seen in patients of lichen planus. It is seen in patients of pemphigus, bullous pemphigoid, staphylococcal scarlet skin syndrome, toxic epidermal necrolysis, etc. But not lichen planus. So feature of intraepidermal split. So the correct answer becomes option number 4. This is actually not seen in the lichen planus patients. Great, great. Now we are going to the next question. So please remember, you can get these type of questions. The clinical picture is given. They have given you some options which are, you have to find out what can be the incorrect statement related to this condition. Can you tell me if you have to describe the lesion of lichen planus? We use 5 P's. Can you tell me what are the 5 P's of lichen planus? What are the 5 P's of lichen planus? Anybody here can tell me the answer? You get plain topped, polygonal, purple, pruritic papules. So we have plain topped, polygonal, purple, pruritic papules. Okay, very nice, amazing, great. So I think this question is very easy. Now let's go to the next question. We have a 40-year-old male who presented with the following lesions. Now what you can notice that there are some lesions, some erosions, crust, blisters on the extremities, on the body. And the second picture here, the picture number first here, shows the mucosal lesion. Now, they are also giving a hint that the immunofluorescence shows IgG on the intercellular space. What can be the most probable diagnosis? So, what will be your answer here? Anyone can tell me the answer here. First of all, if they are talking about immunofluorescence, means they are talking about, some immunobullous disorder. Okay, that vesiculobullous disorder which is immune mediated, and that is why the direct immunofluorescence is positive. Now, if the IgG is intercellular, it means that the split should be intraepidermal. In intraepidermal, if you remember my classes, I told you mainly two autoimmune conditions with intraepidermal split. One is pemphigus foliaceus and another is pemphigus vulgaris. How to differentiate pemphigus foliaceus from vulgaris? We look at the mucosal lesion. Please remember, mucosa is spared in the foliaceous patient, while mucosa is involved in vulgaris patient. So according to that, the answer should be option number 2. Now I have made a simple approach to solve the question of vesiculobullous disorder, which I want all my students to know. Approach to solve a question of vesiculobullous disorder. Okay, first of all, look at the type of bulla. Whether the bulla is flaccid or whether it is tense. These are the two things which we have to notice, we have to look for. If it is flaccid, it can be either pemphigus foliaceus or it can be either pemphigus vulgaris. And if it is tense, either it is bullous pemphigoid, pemphigoid gestationalis, and linear IBS disease. Okay, these are the tense bulla related diseases, and the first one is the flaccid bulla. Now, how will you differentiate foliaceous from vulgaris? When we look for the oral lesions or mucosal lesions, they are absent. So, better term than oral is mucosal. You do not see mucosal involvement in foliaceous, but mucosal lesions are seen in the patients of vulgaris. So, whenever you get a flaccid bulla, the next thing you do is you will look for the mucosal involvement. You will get your answer. In tense bulla, the next thing you will look at the age of the patient. Elderly patient associated with itching and dense bulla. Think of bullous pemphigoid. Pregnant patient, pregnant female with itching or itchy bulla, that is pemphigoid gestationalis, and a child with itchy bulla, linear IgA disease. Please remember, this is very important and a very simple trick to solve the question of immunobullous disorder, that is vesiculobullous disorders, which is secondary to the antibodies. Flaccid may there are 2 options, tense may there are 3, and there are some other points which will help you make the diagnosis. Clear? Can I get a quick thumbs up? So with this, we are done with this question also. Let's move to the next question. This is our next question. We have a 30-year-old male with a large, foul-smelling, spreading exuberant ulcer, bright red granulation tissue over the glands. There were no lymphadenopathy. What can be the most likely diagnosis here? Now, somebody is asking about Covenant's phenomena. Please remember that Covenant's phenomena is a phenomena where the trauma induces the lesion. So, in a patient with existing skin condition, for example, if there is a patient of Lichen planus, and if there is a trauma, the patient will notice that on the site of trauma, the new lesions of Lichen planus have developed. That is Covenant's phenomenon. Same thing you see with vitiligo also, with psoriasis also. Okay. Now, let's discuss this question. For this, we have an approach to solve a question of genital ulcer, and I'm sure anybody who's attending my class must be knowing it. So, what is the approach to solve a question? The first thing is step number 1, we look for the incubation period. Whether the incubation period is short or long. Short means less than a week and long means more than a week. Please remember, short incubation period is a feature of chancroid herpes, while long is a feature of syphilis, donomanosis, and LGB. Step number 2, we will look for the status of inguinal lymph node. Whether the inguinal lymph nodes are enlarged or not. If it is enlarged, whether it is painful or painless. We are talking about the lymph nodes here. And the third thing is step number 3, we have to look for the status of or the morphology of the genital ulcer. How does genital ulcer look like? Morphology of genital ulcer. Please remember, usually with no genital, no lymph nodes, and an exuberant red ulcer with granulation tissue, this becomes the diagnosis of donovanosis. This becomes the diagnosis of donovanosis. Second, if it is a painless ulcer and the lymph nodes are also painless, the ulcer is also hard, this becomes syphilis. Painful ulcer and painful lymph nodes, this becomes your chancroid. While painful lymph nodes but no ulcer, this becomes your lymphogranuloma venereum. In LGB patient, usually at the time of presentation, you do not see any ulcer. So this is a very simple approach to solve the question. Look at these 3 points. First, the incubation period. Second is the status of lymph node. And the third is morphology of the ulcer. Now let's use this approach and try solving this question. First of all, nothing is given about the incubation period, so we will just skip that step number 1. Step number 2 says the status of inguinal lymph node, which clearly mentions here that there is no lymph node enlargement. And if you see, the question shows exuberant ulcer with red granulation tissue. What will be your answer? The answer is Cheliametobacteria granulomatous, which is the causative agent of donovanosis. And if you have seen in donovanosis, we have already seen that there is no lymph nodes and there is red exuberant ulcer. So all the points favors the diagnosis of donovanosis. And what is the causative agent? It is Cheliametobacteria granulomatous. I hope you have understood this. Can you all give me a quick thumbs up on this? Okay, Anuj, Aradhana, Kanchan, Saurabh, Akansha, Roma, Nitya, Subha. I hope this is clear. Very important, very frequent. You can go through all my lectures on eMedicoz app. There are so many approaches to solve the questions of STD topic, which is very important. I've made the approach to solve the urethral discharge syndrome, vaginal discharge syndrome. We have already discussed genital ulcer. I've told you vesicular-bullous disorder also. So all these approaches you'll find it on my eMedicoz app dermatology course. But I hope this is easy for you to understand. Please try solving more questions using this particular approach. Moving to the next question, a patient was treated with steroids for psoriasis. On stopping the treatment, he developed fever, malaise. The lesion as shown in the image below. What is the most probable diagnosis? Now, what can be the diagnosis here? And anyone, what can be the diagnosis here? Now, first of all, we have clearly mentioned that it's the patient of psoriasis and the patient was given steroids. Please remember, we never give steroids in a patient of psoriasis. Steroids are contraindicated, especially oral. Systemic steroids are contraindicated in psoriasis patient. Okay, in psoriasis patients. Oral steroids are contraindicated in psoriasis patients. What is the reason? Because when you withdraw these steroids in a psoriasis patient, there is sudden exacerbation of the lesion. Instead of improvement, the lesion becomes more widespread. The disease will spread even to the uninvolved areas, and that is why we never give steroids in a patient of psoriasis, systemic steroids. If you give systemic steroid, you can see 2 types of psoriasis. One is erythrodermic psoriasis. Erythrodermic psoriasis, where more than 90% of the body becomes red. So patient of psoriasis will take steroids. Initially, the psoriasis was limited to the extensors like elbow, knee, scalp, palm, sole, and he accidentally took systemic steroids. What will happen when the patient will stop? The lesion will become more widespread. Initially, they were only on the extensors, but on stopping, because of rebound phenomena, more than 90% of the body will get involved. This is known as erythrodermic psoriasis. Instead of erythrodermic, sometimes steroid withdrawal will give rise to generalized pustular psoriasis, where more than 90% of the skin gets these pustular lesions. Patient can also develop associated fever, malaise, or systemic upset, and we have given it a name known as von Jumbush disease. So please remember, steroid withdrawal can cause either erythrodermic psoriasis or pustular psoriasis. With this clinical picture of lot of pustules, definitely the answer becomes generalized pustular psoriasis. Nitya, yes, definitely we'll be using all these approach in our classes on eMedicoz app. Yes. Okay. So please remember, this is actually a patient of von Jumbush disease. Von Jumbush disease is nothing but generalized pustular psoriasis with systemic upset like fever, malaise, raised polymorphonuclear cell, even arthritis or arthralgia like features are seen. Both erythrodermic and generalized pustular psoriasis or von Jumbush disease can be triggered by the withdrawal of systemic steroids. Okay, I hope this is clear. Chalo, let's go to the next question. An alcoholic patient presented with a lesion as shown. He also had diarrhea. What can be the diagnosis? First of all, tell me what is happening in this patient. What is happening in this particular patient? What is the diagnosis here? Very nice. The diagnosis here is vitamin B3 deficiency, which is known as pellagra. What is pellagra? Vitamin B3 deficiency. What is vitamin B3? Niacin or nicotinic acid or niacinamide. Please remember, what is the precursor of niacin? Tryptophan. So if there is deficiency of tryptophan, there will be no niacin formation in the body. And if there is no niacin formation, definitely the patient will show the features of pellagra. Can you tell me what are the features of pellagra? Anyone? What are the 4 Ds of pellagra? Dermatitis. Please remember the dermatitis is specifically on the photoexposed areas on the neck. What do you call it? Cassell's necklace. So it is photodermatitis. Second is patient gets diarrhea, patient gets dementia, and if you do not treat it on time, patient can even have death. All these deficiencies or all these features is a feature of pellagra. What are the causes of pellagra? Alcoholic, because alcoholic patient do not take proper diet. Patient with malabsorption syndrome, patient with malabsorption syndrome, patient with patient who consume maize and jawar as their main diet. Please remember those who only consume maize and jawar. Maize is poor source of tryptophan. No tryptophan, no niacin, there will be the features of pellagra. In jawar, there is high amount of leucine, and leucine inhibit the tryptophan absorption. Again, the patient will have niacin deficiency. Patient with carcinoid syndrome, too much of serotonin production, and you all know that serotonin is also produced by tryptophan. So whatever tryptophan was available in the body, all got consumed for the serotonin formation. Nothing is left for niacin. So please remember this is very, very classical feature of or very, very common causes of niacin deficiency or pellagra. You can see the Cassell's necklace here. Sun exposed dermatitis is very classical feature. Coming to the next question, a patient with fever, severe joint pain comes to you. She also develops pigmentation of the nose subsequently. What is the most likely diagnosis? Now, this question I want you to answer. Can anybody tell me what can be the correct answer? Everything look like the answer. It could be a melasma patient. It could be Chik sign. It could be SLE. It could be rosacea. So, what is the correct answer? Anyone? Very nice. I'm very happy that you all know this. This is a patient of Chik sign. What is Chik sign? It occurs following chikungunya fever. Now, if you look at this question, there's a history of fever and joint pain. If somebody develops fever and joint pain, following which there is a pigmentation on the centrofacial part, like nose, this is very classical Chik sign. In melasma, please remember there is no history of any fever, joint pain. Melasma is common in pregnancy or after pregnancy. Melasma is common secondary to exposure to the sunlight or hypothyroidism, but not because of any fever or joint pain. SLE may you'll see more of redness, burning sensation. Same with rosacea. But Chik sign is a very classical pigmentation on the centrofacial face. Okay. This is your Chik sign, and with this, we are done with the questions of dermatology. I hope you have liked this session. Please revise all the PYQ given in the eMedicoz app. We have a lot of PYQs and their discussion. Please do that after doing the predictor series of all the subjects. Try to do their questions also. So, thank you all of you. Good night. All the best for your exams.